Tonight, though, we are honored and delighted to have David Goldhill with us. David wrote a wonderful book that came out last year that has gotten lots of attention called Catastrophic Care, How American Healthcare Killed My Father and How We Can Fix It. David received a BA in History from Harvard, a MA in History from NYU. He's president and chief executive office of the Game Show Network, which operates U.S. cable TV network, a U.S. cable TV network seen in 75 million homes, and is one of the world's largest digital games companies. He's a member of the board of directors of the Leapfrog Group, an employer-sponsored organization dedicated to hospital safety and transparency. He wrote this book inspired, as I'm sure you'll hear, by his own family experience. He wrote an article for The Atlantic that got a lot of attention and then led to this book. I decided it would be great to have him speak this evening because he provides a lot of interesting perspectives, both based on his own personal experience, on his reading, on what it's like to be a family member, on the perspective of someone who's been involved in the business community in many ways, and also the fact that anyone can have an impact on these important debates that are taking place in our country today. You too can write an article, perhaps a book, and help influence a discussion. So without further ado, please welcome David Goldhill.
Thank you, Ron. Thank you, and thank you for choosing to spend this glorious day of an unexpected heat wave inside. I'm from the small but growing minority of people who look at our healthcare system and suspect that a lot of the problems that have grown up over the last 2 decades are a result of our assuming that healthcare is so different from everything else, so different from every other business activity, so different from every other consumer activity, that it requires its own economy. And the argument I make in my book and in articles is that this economy sends all the wrong signals to providers and to consumers. It encourages a massive amount of overuse. It discourages prices from disciplining the system as it does in everything else. It impedes the right type of innovation, encourages often the wrong type of innovation. And then most directly, and most immediately in my family's case, encourages a culture of sloppiness that is truly different than anything else we see. Now, as I mentioned, it's a minority viewpoint, but it's growing, and it's growing not just in this country, but in others, as we recognize that many of the assumptions we have about healthcare are 20th century assumptions, maybe even 19th century assumptions. And the world has changed. Healthcare has grown to become our largest industry, our single largest source of consumption. It is no longer what it originally was, which was something we use rarely, only when absolutely urgent, and only infrequently with good results. Healthcare has been integrated into our lives in a way that would have been inconceivable when any of the healthcare systems around the world were created. And yet many of the assumptions in which those healthcare systems were created, many of the reasons they were created, not only still are conventional wisdom, but dominate the political debate. I'm going to talk tonight, at least to start, I'll spend about 20 or 30 minutes on a presentation about what I regard as the founding myths of healthcare that have gone largely unexamined, and that the last 2 or 3 generations suggest are no longer true, and yet they dominate our thinking. And then we can spend 45 minutes, I guess, taking questions on game shows. But let's start with healthcare. Why am I here? I'm not a healthcare person. I guess I've sort of become one over the last few years. It's my very time-consuming hobby, and I'm very grateful to my employer that they let me free for that hobby. But my interest in healthcare started with what happened to my father. My father in 2007, in October, walked into a hospital feeling some shortness of breath, but he was quite healthy. He went to work that day. The hospital suggested keeping him for observation overnight. Unfortunately, gave him an IV that it looks like gave him an infection. 5 weeks later, without ever leaving that hospital, he was dead. He died of an infection acquired in the hospital. And, if you've ever been through this as a family member, even just being with a loved one for an extended hospital stay, you'll notice a lot of strange things about the way hospitals work, particularly if you spend any time in the rest of the economy. They're quite disorganized. They're not obvious economies of scale, of size. They're not obvious economies of scope of doing lots of different things. In fact, both size and scope seem to hurt the way hospitals operate. If you've got a loved one in a hospital, your physician is likely to say to you, you know, it's best if there's a family member around at all times. Because hospitals make large numbers of mistakes, almost inconceivable mistakes in an era in which IT runs everything else in our lives. I often use the example of we're so used to hearing that we don't think to ourselves, imagine if we took a package to FedEx and FedEx said, we'll get your package there, but it would really be best if someone stayed with it along the way. And yet, none of us are surprised to hear it would be best if you have a loved one, if you were with your loved one in the hospital, or somebody was. And if you spend 5 weeks with a loved one in a hospital, even in an intensive care unit, as I did with my dad, you'll see him taken for tests meant for other patients. You'll see doctors come in who have forgotten who he was and forgotten what the conditions are. You'll see tons and tons of errors. It's truly astonishing. And ultimately, the biggest error of all is the one that cost my father his life. About 4 or 5 weeks after my dad died, Atul Gawande wrote a piece in the New Yorker in which he talked about a physician, Peter Pronovost, who's been running around the country trying to convince hospitals to adopt a series of protocols, mostly involving washing your hands, basic sanitary stuff, that where it had been tried had reduced the rate of hospital-acquired infection deaths by somewhere between 2/3 and 3/4. And that cost basically nothing. It was fundamentally cultural and managerial. And I'm a business guy. And something struck me as incredibly and profoundly wrong about that story. Gawande's piece is actually a heroic piece about how Pronovost is tireless, and I've gotten to know him. He's tireless in pursuing this. But I had a completely different perspective. I'd run a movie theater chain. And we had a rule in this movie theater chain, which is if a soda spilled and it wasn't cleaned up within 5 minutes, the manager of that particular theater was in trouble. Why? Well, it wasn't because of liability. It wasn't because we were afraid somebody was going to break their neck and sue us. It was for something much smaller. It was because Saturday night business at a movie theater is date night for young married couples. They invested in the babysitter. They finally get a night out. They come into your movie theater and they see spilled soda in the lobby. It changes the whole experience for them. It means maybe next week they go to a different movie theater. Small. Minimum wage workforce. And yet you can easily get it done. What is it about healthcare that meant that Pronovost was having to sell, desperately sell, a series of protocols that saved lives? Forget about save money, save lives. Right? We don't get, the movie theater business, we don't get to save lives that often. It struck me as astonishing. And it got me started on what's now 6 years of work on the question of what are the incentives in healthcare? Why isn't it automatic and organic that when someone comes along with a better idea to improve quality, improve safety, improve efficiency, it's adopted? And almost all of my work is about that. Why those incentives in almost everything else in life drive better behavior, often in pursuit of a dollar of profit, frankly, and in healthcare don't. And the major reason, I believe, is because we have created this economy in healthcare that incents almost the exact opposite of what we have. And the biggest problem number one, is we have the wrong customer. The customer in healthcare isn't any of us. It's big insurance companies, CMS, which is the agency that runs Medicare, and the state agencies that run Medicaid. They are the customer. And if you've worked in enough industries, and one of the benefits of not being able to hold a job very long is you get to see a lot of different industries, as I have, you see how the actual identity of the customer determines how you behave. Those of you who are students know that the way you perform in different classes depends on who the professor is, who your customer is. It's fundamental. But we've taken ourselves out of that equation in healthcare. We are not the customer, and we all know why. Because without insurance, healthcare could never be affordable. Now, that statement is so obviously false because clearly all the money to pay for healthcare is coming from us. It's just running through insurers. Almost every economist will tell you anyone who believes that employers are really paying health insurance premiums doesn't know anything about economics. We just sit there and say, how much does an employee cost us? Whether we pay it in insurance premiums, salaries, days off, is irrelevant. It's all coming from the same place. And so one of the first things I did is go look at one of my young employees, one of GSN's young employees. I looked at a 23-year-old woman who was in a good entry-level job, an executive track entry-level job. earning now about $35,000 a year. This is 2 years ago. And I asked myself, over her lifetime, how much is this woman, she's Becky in my book, going to put into our healthcare system? So she's obviously going to pay her share of our healthcare premiums. We have a very good health insurance plans, like most entertainment companies. It's pretty strong, pretty robust. She's also going to pay our share, because it's just coming out of what we can afford to pay her over her lifetime. She's paying her deductible, out-of-pocket, other out-of-pocket expenses. She's also paying an enormous amount of taxes. She's directly paying Medicare tax, Part A tax. And now, somewhere, depending on the state she lives in, between 15 and 30% of the total taxes she pays to state and federal government is going to fund health care, including some that, in theory, she'll get when she's Medicare eligible. So what does it mean for Becky? What it means for Becky is that, assuming she has kind of a typical life, gets married, has a couple kids, lives till 80, retires at 65, assuming she doesn't get rich, her income grows about 3% a year, which was the average before the Great Recession and hopefully will be again, and she never gets really sick. None of her family members get really sick. If the cost of healthcare goes up by zero, for the rest of Becky's life, she will put into the system $1.2 million. If it goes up by the amount that the Affordable Care Act suggests will happen over the next 10 years, if the act is successful in containing costs, she will put in this number, $1.9 million. If Becky has a working spouse, together they will put in $2.5 million. So when we say that insurance and Medicare and Medicaid have made the system affordable, let's think that through. Hasn't what it really done is take money out of our pockets in a lot of different places, add an enormous amount of administrative cost to it, build in a tremendous amount of complexity, distortion of the very economy, and then return it when we need it? Because if you look at almost everybody in this country who ever has a job, I guarantee you they are putting far more into the healthcare system than they are aware. There are very few. So just to give you a sense, Becky over her lifetime will earn about $4 million in the future value case, where I increase it by 3% a year and there's inflation and all the rest. So roughly 35, 40% of that, and she's middle class. Now she doesn't know, right? The part she'll know about is the 570. Right, that's the part that gets people like Becky to say, we need expanded coverage. Because she doesn't aware that she's paying it here. But there are very, very few families who will put less into the less into the healthcare system than they take out. Because a healthcare system as a payment system is the most expensive imaginable payment system. Well, we all know one of the benefits is that insurers and Medicare and Medicaid can drive much better prices than we can as individuals, right? Except there are no prices in the healthcare system. They're entirely fictional. They bear no relationship to the purpose of prices and anything else, right? Which is to compensate for real cost, including opportunity cost and the cost of capital. This is the bill that Medicare sent to my father for the hospital service of killing my father. $635,695.75. My mother's share was $992. That sounds like a fantastic deal. Everything in healthcare presented like that sounds like an incredible deal, which is why we do it. There are very few places where you can buy something for $630,000 for a mere $900. Except for the fact that what they did is they took my father and looked at him for a day and then killed him, which arguably wasn't worth that money to us. I know my mother certainly didn't think it was worth that money. But look at these prices. What are they? They're nonsense. So I did a little experiment. I said, let's say Dad was the first Jewish king of Saudi Arabia. And instead what I did is I got him a room at the Four Seasons, a suite at the Four Seasons, which is the most expensive hotel in New York, and leased all this hospital equipment, put it in his room, gave him round-the-clock nurses, gave him an hour a day to see his physician, gave him room service for all his meals, and this is very important. It's one of the great things about the Four Seasons. TV's free. So you don't have to, hospitals is $9 a day. So Dad is king of Saudi Arabia, runs up retail, a bill of $155,000. I will tell you the hospital where Dad died was not nearly as nice as the Four Seasons. and the food wasn't as good. But this just gives you an idea of how meaningless this is. This tells you nothing. This is useless information for making any decisions whatsoever. Well, okay. Here's what all the conventional experts say. They say, yeah, that's all true. But the reality is, in healthcare, spending isn't normalized. It's completely random. Anybody could have this terrible thing happen to them. And in fact, and by the way, if you ever get invited to a healthcare conference, you want everybody in the room to nod their head and smile. You say the following. You know, in any given year, 75, 65, 80, depends on what the number is that year. It's now down to 67%, we guess. Of all healthcare expenses is accounted for only 10% of the population. So you can tell yourself we're all putting in all this money, but what we're really doing, like any insurance system, is we're protecting you against this. You're in that. And that sounds persuasive. And that piece of information is now 60 years old. And it's also meaningless. Here's the percentage of cars bought by 10% of the population every year. It's 100. Actually, 8% of us buy all the cars every year. College educations, weddings, refrigerators, vacations, divorces, you name it. One of the things that convinced me that healthcare economics is an island is that healthcare economists say this and seemingly know nothing about the markets for any other goods and services. So here's how the markets for all expensive goods and services work. If they're universally used, and for the most part we all buy a car at some point, they're not universally used every year. In any given year, 8, 9, 10% of us buy all the cars, but we'll all buy cars. It's true of almost everything on this chart. In fact, it's true of almost everything that isn't an ordinary expense. What makes healthcare unusual, totally different than everything else, is that the other 90% of the population still spends 33%. It's the exact opposite of what the whole system is based on. That's true. Now, obviously, cars are a voluntary purchase, and healthcare feels like it isn't a voluntary purchase. The reality is, some percentage of this 10% is really sick. And it's going to be in that top 10%, a tiny percent is in the top 10% their whole lives. They're born with terrible illnesses. Another percentage is sick for a long period of time, a long-lasting cancer treatment, for example. But unfortunately, or fortunately, almost everybody in this room is going to have their year in that 10%. This doesn't tell you about concentration of healthcare spend, because it's done on an annual basis. And we live for 80 years. Over 80 years, this distribution is almost completely normal, with the outliers being those who are really sick. But think what we've done. We've built an insurance system that covers risk, all risk. This is all of it's rare. In healthcare, we've actually built an insurance system to cover certainty. The certainty that all of us are going to get sick. Imagine if life insurance didn't protect you against dying early. It protected you against dying at all. The premiums would be greater than the benefit. If all of our homes burned down, the only homeowner's insurance you could have is against burning down this year versus at some point. Let's take that analogy a little further. You own a home, there's a chance your home burns down. You want to be insured against that, because it's a 1 out of 300 chance, and a pool of 300 of you bear that risk better. What about the risk of your furniture going out of style? We could argue, if we use the healthcare metaphor, we could say, well, furniture goes out of style, that's a terrible thing. Who can afford to replace all their furniture in 1 year when it goes out of style? So let's insure that too. Now we know what happens when we insure everybody against their furniture going out of style, which is everybody's furniture is constantly going out of style. That's what we've done in healthcare. We've confused the fact that there are some risks that are rare, catastrophic, and major with the way healthcare started, which is that all healthcare risks felt that way. So, one of the great benefits we all know is Medicare. And when you talk to the people about reforming Medicare, this is who they focus on. Those Medicare patients, it's about 16, 17% of the Medicare population, that use a lot of healthcare. $22,000 a year for this group is current spending. And this is what the healthcare experts concentrate on. How do we get the spending down by those who are using the system most intensely. They're looking in the wrong place. We will spend $11,900 a year on seniors who are in good or fair health. We will spend $5,500 a year on seniors who are in excellent health. What we've done in Medicare is we've said, uniquely in the world, by the way, nobody else has a public health care program as an entitlement. They all have budgets. We've uniquely said, anything seniors need, we'll pay for. Guess how the industry responded? Have I got a need for you? And if you have a parent who's a senior, and my mother is a senior, and obviously my father was a senior, it's extraordinary how much health care they consume. That sounds like a good thing until you remember Becky. Because what we're doing is saying to people like my mother walks to work in heels. She has foot problems. A woman her age who works is in terrific health. Her podiatrist gives her a shot every few months for her foot problems and has never said to her, have you ever thought about wearing sneakers when you walk to work? Why would he? Now, obviously, not all of the health issues that seniors are dealing with are that pedestrian, to use a pun. Glad somebody caught it. But, in fact, if you think about society's limited resources, once you say to any industry, and I guarantee if I said to the game show industry, we would respond. We will buy anything you need. We will expand that definition of need. Look very closely at what your senior relatives consume in terms of health care. Obviously, some are here. But there's a lot of money in here. And a lot of it only makes sense if you don't think about what that money could have bought. Let me tell you my single favorite Medicare statistic. I have never heard a single politician refer to it. In 1965, when seniors paid essentially all of their health care cost, the average senior bore health care expenses of somewhere around 10, 11% of their income in 1965. Medicare started in 1966. Today, seniors pay roughly 5% of their total health care spending is out of pocket. The other 95% is picked up by all of us. That 5%, the amount they pay, is now equal to 17 or 18% of their income, depending on how you count. So what we've done with this wonderful benefit is we've expanded the amount of care they get. We've protected the outliers, which I would argue should have been our goal, the people from true disaster, from true healthcare problems. We've incented enormous amounts of ends-of-life care because you get paid for it. Why not do it if you're a hospital? They're on autopilot to do it in most places. And the seniors are paying more than they were paying before Medicare. We spent $5 trillion on Medicare. When I first started talking about consumers in healthcare, one of the Obama administration officials commented by saying that everyone knows consumers can't fend for themselves in healthcare. It's impossible. And it sure looks impossible. We go out there are no prices, there are no metrics, there are often not even directories of clinics. So this man here, Kenneth Arrow, is an economist at Stanford, Nobel Prize winner, and a truly brilliant man. And he wrote what's probably the founding article in healthcare economics. It's 51 years old, this article. And what it said was healthcare could never be a normal industry because consumers never know enough. They don't have enough knowledge. The doctor will offer them a service, might even say this is necessary to save your life. What's a consumer going to do? Buy. So how can you possibly have the normal discipline you have in anything else where you can say, sorry, I don't want that watch, I don't want that car, I don't want this meal, I'll go somewhere else. You can't do that in healthcare, Arrow said. And everybody agrees with that, except every industry is like that. None of us have enough knowledge to buy. I mean, some of us are car nuts maybe, but most of us don't buy cars on that basis. Most of us don't buy anything on that basis. That's number one. So since Arrow's work in other industries, there's been tons and tons of work on how to manage what's called information asymmetry, which is what he was talking about, where the customer knows far less than the seller. It's true of almost any industry. So that's one, but that's less important than 2 and 3. Many of you may recognize the symbol of TripAdvisor. I served on their board for a while. It's a terrific company. TripAdvisor rates seemingly every spot of land on Earth now. And what's interesting about what's happened in healthcare is that the doctor monopoly of information is long gone. When you survey physicians, most of them say that their patients research significantly, and healthcare research is one of those 2 or 3 most used elements of the internet, most used aspect of the internet. In fact, most doctors now tell you, you've got these alternatives. So go home, do some research, and let's talk more. Here's my advice. They know you'll do the research. So information asymmetry common in all industries and handled differently, and less common in healthcare, where more and more of what you do in healthcare is about choice, and less is do this or die. The third element, though, is a more important argument, which is Arrow did not say what the alternative was. He says, well, if we can get the government to just buy healthcare for everybody, that would be great. Because the government is not going to be emotional about it. The government can accurately say, here's what I should have, here's what I shouldn't have. That's not what our government has done. Our government has said, you can have anything the doctor wants and we'll pay for it. It's the worst possible resolution to the point Arrow made. Arrow was saying, you as a consumer are going to screw up because the doctor's going to say to you, buy this or you'll die, and you're too likely to buy it. You're unlikely to say, wait a minute, really? I don't believe that, and I want to talk to somebody else, and you're unlikely to be skeptical. Well, how likely are you to be skeptical if you're not paying for it at all? What we've substituted for this problem has made the problem far worse. So here's what's happened in markets in which consumers actually pay. You may not be aware, but while medical care for the previous 2 decades and physician services and almost every element in the assured economy, prices grew much faster than inflation. Any part of the healthcare economy that was uninsured grew below the rate of inflation. A lot of you may be familiar with LASIK. So LASIK had the exact normal price experience of any new technology. It was introduced, it was very expensive. Once a lot of guys bought the machine, served their patients, prices came down. Why? Because the marginal cost of doing a LASIK is almost zero. And like most expensive technologies, the marginal cost of doing an MRI is zero, almost zero. And what happens in normal markets is you buy the equipment, and then once there's competition, everybody's trying to get whatever revenue and amortize it. Only in healthcare does high technology lead to higher prices. I don't know how much leverage you think you have in cosmetic services, but one of the interesting things is when you look at a study of a reconstructive procedure done after a medical procedure and done for cosmetic reasons, often by the same surgeon, right, to the same type of patient, the price differential's enormous. They charge much more in the insured market for the reconstruction than they do for the cosmetic. Same body part, same procedure, same everything. 2 different economies. Lastly, we've substituted insurers for ourselves because they're so much better at dealing with this, right? They have so much more leverage than we do. My son needed an appendectomy. He actually burst his appendix, and frankly, he's a pretty irresponsible kid, so I wasn't surprised. Everything's a problem, you know? And so we took him in for an emergency appendectomy, and those of you who are fortunate enough to have insurance know this letter. It's the first letter you get back whenever you've had a non-pre-approved treatment. We don't know it was necessary. And in fact, if my son had been, let's say, a dog, there would have been other medical options, like having him put down. His mother is very attached to him, though, and I must admit we never even considered that until after I got this bill from the insurance company, where I thought, wow, did we rush into that appendectomy? This is what a consumer economy looks like without consumers. You know, when that guy, Tom McDonough, said, oh my God, can you imagine poor consumers left on their own? This is the benefit of having someone do the work for us. It's so much harder. I want to be very quick on this point. You know, one of the things we think about all the time is, oh my God, I get hit by a bus, what's going to happen to me? If I can't negotiate. You know, if I have a heart attack, I'm not going to negotiate. And of course, tons of industries have figured out ways to deal with emergency procedures. You know, you have a blowout of a tire on a highway. It is a horrible experience. And even if you don't have AAA or some manufacturer coverage, You know when that guy shows up to change your tire and you're desperate and afraid of getting hit by a car, he's not going to ask you for a net worth statement because there's a market. You have some rough idea of what a tire costs. You have some rough idea of what a service call costs. And so does he. Interestingly, what's happened in healthcare since Medicare is that even inpatient procedures at hospitals are almost never about emergencies anymore. They're about things related to chronic conditions, reconstructive surgeries of many types. If you look about, even cancer, by the way, is no longer, oh my God, we've got to get you in the operating room tomorrow. The reason Cancer Centers of America advertise is because when you have a cancer diagnosis, you have to make a choice of where and how to be treated. Everything in healthcare now, except for the rare getting hit by a bus, involves choice, consideration, thinking about it. This stereotype of getting hit by a bus is, again, using the smallest possible incidents to drive a whole system. It's like we drove the entire tire market just on blowouts. I talked a bit about Medicare and seniors. I'll spend just 1 second on this. Everybody focuses on the problem of Medicare as a problem of money until you've had your parent killed by an undisciplined healthcare system. And then you think about this. 1 out of 3 Medicare beneficiaries has surgery in the year of their death, even though the rate of recommended surgery declines meaningfully as you become a senior, because your opportunity, the risk-reward just changes so much. There's almost never surgery recommended for 90-year-olds, and yet 1 out of 5 Medicare beneficiaries who dies in their 90s had surgery in the year of their death. This is what a system that doesn't face normal discipline does, right? If you have a senior admitted to a hospital, there's a 1.5% chance that admission is going to lead to an accidental, a death from error. 1 out of every 165 runs the risk of what's called a never event, which is something considered so sloppy, so amputating the wrong limb, wrong blood, things like that. This should never happen. They happen. These rates are so high, they're greater than the rates of death in combat. So here's the big one, right? There have been thousands and thousands of scholarly articles written on how technology is driving up costs in healthcare. Almost all of these articles were written on $250 laptops. Nobody noticed the irony. What's really happening? What's really happening is this. This is 1965. In 1965, DEC, a company that importantly no longer exists, introduced the first mini computer. It was roughly this size. This is a mainframe. This is the first computer designed for somebody other than NASA and GM and the Defense Department. Right? A mere big company could actually use it to process payroll. So the price of that was $19,000 in 1965. At the same time, the average American spent $250 on healthcare, which means that the price of a computer, the most complicated piece of equipment, probably usable by only a few 100,000 people worldwide, was 80 times the price of healthcare. Makes sense, right? Fast forward to today. Every single one of you, I would bet, is carrying in your pocket something meaningfully more powerful than either of those machines. Many of you are using them now or wish you were. I'm curious, frankly, as to what's on mine. You paid somewhere between $200 and $300 for a top-line one, which is roughly 1/30th to 1/40th of what the average American will spend on healthcare this year. How did that happen? How did the most complicated thing on earth change in price relative to the most personal accessible by 3,600 times in 2 generations? What happened? Do you really believe it's because technology drove up the cost of this? Really? Here's what happened. It's really simple. In this world, every day, men and women wake up in the morning and say, how am I going to make my billion? I know what I'm going to do. I'm going to make it smaller, easier to use, cheaper, funner, more accessible. I'm going to invent a color no one's seen before. I'm going to come up with an app that all it does is enables you to avoid text messaging charges. I'm going to do this. I'm going to do that. I'm going to make it better, simpler, more accessible, cheaper, easier to understand. Well, here's what didn't happen. The entire population did not get computer science PhDs so that we could all use this. People made fortunes making it easier, simpler, cheaper, better. Nobody in healthcare can make more money that way. At all. No matter what you think. If you really understand the business models of doctors, clinics, insurers, hospitals, drug companies, there is not a single man or woman who walks into the healthcare industry in the morning and says, I know how to make my billion. It's the Walmart of healthcare. It's the low-price leading hospital. That loses money. I know how to make my billion. The safest hospital on earth. You go to whatever hospital your insurer tells you have to go to. That doesn't make any money. I know how to make more money. The most accessible practice whatsoever. You can reach me by email. You can reach me by phone. You can reach me 24 hours a day, or me or my partners. Well, insurers don't reimburse for that. You can't make money doing that. You lose money doing that. Every one of these pluses loses money in the business model of healthcare. So when you hear healthcare experts talk about it, it's complicated, technology is difficult. Look, your dry cleaner adopted information technology. And it wasn't because of the Dry Cleaning IT Act of 1997. It was because your dry cleaner competed with the dry cleaner across the street. It's the reason everybody adopted information technology. This is a place where information technology would save lives, create enormous efficiencies, and get rid of that chaos you see whenever you walk into a doctor's office or a hospital. It hasn't been adopted because no one makes more money adopting it. And what the government's had to do is say, hey, we'll pay for all of it if you just adopt it. But that doesn't change anyone's incentives. If it took you longer to write a paper on a computer, how many of you would use computers to write your papers? Even if the school gave you computers, you still wouldn't do it. Innovation is a result of this. This is the most important innovation of the post-war era. It's a box. For those of you who know the story of the shipping container, nothing has transformed the world economy more than this. And it's the stupidest idea on earth, right? Because from the beginning of time, the cost of a voyage was the voyage, which were dangerous and scary, and things got lost. And so what'd you do? You pack the ship as efficiently as possible. That's what longshoremen did. You used to take a week to pack a ship. Then some guy came along and said, I got a great idea. Let's fill ships with space, just air. But if we put them on standardized boxes, they can come off ships, onto trains, onto trucks. No one ever has to unpack them. You don't have to worry about the configuration of a ship, or you don't have to worry about the goods. Just put everything in a box, put all the boxes in there. Crazy idea, right? It cost a ton of money to reconfigure every port on Earth. Meant that most ships now are filled with air, but by the way, that's why we've had to expand the Panama Canal, because ships are now so large. Eliminated hundreds of thousands of longshoremen jobs, and God knows how much in wages, as that went from being a very skilled profession to a completely unskilled one, or actually a highly skilled one, but operating, you only need 5 guys to operate cranes in most ports. It's estimated that because of the effects of the shipping container, particularly the globalization of trade, that 1 billion people have been lifted out of poverty. Roughly 90% of the world's supply inventory is no longer needed to be kept near a factory. There's probably nothing that has ever changed the economy as much, but I want you to imagine in healthcare, somebody walking in with an idea that says, going to put most people out of jobs who have them. It's going to involve a lot more upfront cost. And it's going to do something enormously inefficient, fill ships with air. What are the odds that that gets adopted in our healthcare economy? What congressman supports that? What city councilman lets that hospital be built? I want to turn to one macro issue because it's asked about all the time. And that's what we all know. It's this. Here's another thing that'll get you a lot of nods in a healthcare conference. The left side is life expectancy. And this is percent of GDP spent on healthcare. And these are the 30 OECD countries mapped out. Needless to say, this is us. And we all know what this means, right? This means the United States spends a lot more money on healthcare than anyone else and gets a lot worse result, right? So ignore the US dot. Where's the line? There is none. There's no solution to that. You know why? Because healthcare spend has almost nothing to do with life expectancy. When you look at the factors in life expectancy, the big ones, income, quality of life, which means diet, exercise, family structure, education, environment, all these things way ahead, no matter how you measure it, who measured it. Higher than healthcare, accident rate. If you're good on road safety, and you're good on guns, you save a lot more lives than healthcare does. There's no relationship whatsoever. And when was the last time you heard a politician say, hey, I know spending more on healthcare has nothing to do with keeping people alive? It is arguably the least important factor we can think of. When the Affordable Care Act was passed, I wrote an article that asked a question that, as far as I could tell, nobody had ever asked and no one ever answered, which is, as a Democrat, I get that we want to help people. So we're going to spend $200 billion a year on the Affordable Care Act, $100 billion of government money. The estimate now is much larger, $100 billion of people's own money. Can we think of any use of $200 billion that would have less of an impact than more healthcare? Well, that's crazy, right? But all healthcare conversations are dominated by experts on healthcare. Nobody sits there and says, gee, maybe we should spend $200 billion more on housing or education or parks. Maybe we should give everybody a week off or 2 weeks off. And yet we know, particularly at lower income levels, these have a much greater impact on health. This is not the story of our doing terrible. In fact, if you look at the top numbers there, it's Sweden, Italy, and Japan. Okay? What do their healthcare systems have in common? Absolutely nothing. But these people live like Swedes, Italians, and Japanese. Those are long-lasting lifespans. The bottom, US and UK. What do our healthcare systems have in common? Nothing. But we live like Brits and Americans. We drink, we take lots of risks, we do stupid things. Thank God we watch a lot of TV. So the last myth, it's all complicated. I may be the only person who talks about healthcare who argues this is wrong. I could spend hours with you debating all the little things about bundled payments and fee-for-service and cross-subsidization and all the stuff that excites most of the debate and informed most of the Affordable Care Act. But it's really all about this. Nobody providing you a healthcare service has the right incentive. Doesn't mean that people aren't good. Doesn't mean that people don't go into medicine or hospital administration or even health insurance to do good. People do everywhere. There's lots of near saints in this industry, and to some extent that's confusing to us. But we're asking people, when they practice sainthood, to compete against their economic incentives. The economic incentives in healthcare, where you have someone who will pay for all needs, is do as much as possible, at as high a price as possible, at as high a cost as possible, because a lot of guys will reimburse you for your cost. You can imagine what that does to cost. And don't waste money on the things that don't matter. Customer service, making it easy, making it accessible, making it efficient. Can't get paid for that, you don't do it. Healthcare policy involves a lot of those enormous issues. But one of the benefits that I think people who have my point of view have is that we're all actually consumers of this. And so daily, literally daily, I get an email from someone saying, you won't believe what happened to me. And it's a story, right? And we all have these incredible stories. Charts lost, doctors who don't coordinate, patients treated for the wrong things, loved ones kept in emergency rooms for 10, 12 hours. What I ask in thinking about healthcare is not to think about the big picture for a second. Think about the little picture. There's 315 million little pictures, and I've never met anyone who doesn't have a story. Those stories are unique to healthcare because healthcare is unique. Because we've given it a pass. We've said it's okay to be unlike everything else, to have your own world, judged by your own rules, with your own payment system. To some extent, we like this. We like not being the customer. Being the customer seems hard. But when being the customer seems hard, I ask you to think about your phone. Somebody took the most complicated, imaginable device on earth and figured out a way to make you love it. love having it, love buying it, can't wait for the new one, can't believe all the stuff it can do. That's healthcare. It is unbelievable what healthcare is going to be able to do. It's unbelievable what healthcare could do now if 15, 20 years ago the healthcare economy was normal. It's not too late to fix that, though. And I suspect that we're about to. Thanks very much. I have time. Others, I'm sorry for going on so long.
So don't be shy. The floor is open.
I was wondering how you think this might have been different, if at all, if the public option were left in the Affordable Care Act.
So I think the problem with the public option is the public option was perceived to work the way Medicare was. So one of the things that's unique about the United States that I think many people who are Medicare fans don't understand is that no other country on earth has health care paid for publicly without a budget, right? So Medicare has no budget. And unfortunately, once you have no budget, you set off all of this really bad stuff. And unfortunately, the public option is going to work that way too. If you talk to the people who favor these programs, what they will say to you is, it's complete bullshit. Healthcare need is what it is. I'm completely wrong. Nobody voluntarily gets cancer. But of course, that's not really what it's about, right? It's about how you treat cancer. It's about how efficient you are. It's about what your costs are, how you control them. As long as the incentives are, whatever you do, we will pay for, you're never going to get an efficient, customer-oriented service. And it's the reason for the first slide is because the public option is a terrific way of disguising who really pays for it. There is no way to pay for healthcare without us paying for healthcare. And the amount of financial engineering in healthcare done by people who hate investment bankers is extraordinary. This may be the most complex financial engineering of anything in our society, all designed to prevent you from ever noticing how much you paid. And unfortunately, the way the public option was designed, it was likely to wind up in the same place. I will mention just one other thing, which is that healthcare knowledge in this country seems to have stopped existing in sort of circa mid-70s Europe. So you may be aware that almost every European nation now has gone through this enormous question of their healthcare systems. Many are fairly happy with them, but almost all of them run into these sort of same cost issues, demand issues. They're willing to explicitly ration through waiting lists and all the rest and saying no to procedures. Any observer of the US political system knows that as soon as you say no to a senior, to someone in Medicaid, to someone who took the public option, all it takes is a particularly competitive election for somebody to ask at the Des Moines County Fair of a presidential candidate, can you believe they wouldn't let me have my hair surgery? And that's back on the list. And I think one of the things that's unique about the United States is we are highly unlikely to let government programs ever say no to us. In most of the places that's worked, government programs have been able to say no. Singapore is the only system that says, fundamentally, in every transaction, the patient is the consumer. Singapore, for those of you who know, has an excellent healthcare system and spends under 4% of GDP on healthcare as a result. Sir.
How much of this is pharma, if you were going to attack segments? And what can we do globally to try and do that, with the inconsistencies?
So it's a very good question. I mean, clearly, as I think your question gets at, pharmaceuticals have grown enormously, and public programs have been particularly unwilling to use volume buying to drive discounts in pharma. The problem, I think, in most of this is that we've got to be careful of doing static analysis, which is, so we'll spend 300 to 350 on pharma this year, $3 billion. The problem is, arguably the growth of pharma should have significantly reduced healthcare costs. If I told you in 1965 that most chronic conditions were going to be treated by pills that have zero marginal cost instead of going to see your doctor every month, you would have said fantastic. I mean, unless you, of course, were a doctor, you would have said fantastic, right? That's not what happened. We have a non-functioning price system throughout healthcare. And so looking just at pharma is sort of misleading, right? So one of the things we see in the price system in pharma that's most confusing to people is that, the minute something goes generic, the price collapses because, of course, there's no marginal cost. The minute you have competition, the price collapses. But what I think is more interesting is that Me Too drugs, if they're on patent, enter the system at a high price, not at the generic price. right? And that tells you something about how resistant, how reluctant, not just Medicare, but also insurers are to drive price. That relying on them to drive price, is now accepting 50 years of failure as, well, maybe they'll be better next year, which is sort of what the Affordable Care Act hopes. We need a functioning price system. Interestingly, in pharma, and just forgive me for going on so long, but it really is interesting. Pharma is the one area where we're seeing major shortages. Ezekiel Emanuel wrote a piece about, wow, we're seeing shortages in lots of sort of old drugs that have gone generic, but often have very important uses. Maybe if we agreed for a 20% price rise, people would start making them again. Well, of course, what you want in a price system is flexibility. When things are in shortage, the price should go up, people start making them again. And as long as you're going to say, as Ezekiel does in that thing, hey, I've just said it wrong, let me set it here, you're basically dealing with stop clock pricing, right? It's right now. It's definitely going to be wrong tomorrow. It might be too high or too low. In pharma, I think we see a lot of prices that are too high and a lot of prices that are too low. And so we see excesses in some drugs and shortages in others. And I don't think we'll fix any of this until we have a normal price system, because nobody is smart enough. If you spend any time looking at how electricity is regulated, single product, same product everywhere in the country. Electricity regulation is unbelievably complicated. There's an estimated 4 to 5 billion prices in Medicare. No one's smart enough. Sir?
In the context of the 7 myths, a quarter of our spend is in the last 12 months of life.
A quarter of our Medicare spend,
Yeah.
not of our national spend.
Of our medical spend.
Medicare, just Medicare.
And then we're 15% total. So, but whatever.
It is
What
Medicare.
are we going to do about that?
So,
in the context of all your myths.
Right. So, is end-of-life care medical care? I don't know. But here's one thing I do know is that everybody in this room is going to have end-of-life. And a very large percentage of us are going to be fortunate enough to have end-of-life when we're old. And that end-of-life is very medicalized. And I think end-of-life is actually the edge of the wedge for why our concept of healthcare doesn't work. So the concept of healthcare was like your house burning down. Your house is burning down, we need someone to I was about to say blow out the fire. There's got to be extinguish the fire. And someone to rebuild your house. Pretty straightforward, right? And our concept of healthcare was the president said this, you get sick, we'll fix it. Well, that's not how healthcare works. But where it's most obvious now is the enormous amount of money we're spending on end-of-life care. Because there's no medical reason for end-of-life care. Alleviating suffering is an argument, certainly. But what's interesting is that end-of-life care is something where we really see what most healthcare is now, a choice. My wife says she wants to be kept alive as long as there's a single molecule living. I think she just wants to be that thin. I know people who say, as soon as I can't play a good deal of tennis, put me down. There's a wide variety of choices as to how we want to die. Here's what we've done as a society. We've said, we're going to take, the end-of-life number is somewhere around $150 billion this year for Medicare patients. There's some spent on non-Medicare, but $150 billion is what Medicare estimates. We don't actually have a full definition of end-of-life care, but let's say $150 billion. We're going to take that $150 billion from all of you, and we're going to give it back to our seniors only if they agree to have a medicalized death. We're making that choice as a society because it's part of healthcare, right? And healthcare should be paid for. But who are we kidding? Those are individual choices. There's no right answer. There's no right amount of care. And it's the one area in which it makes so clear that what we assumed about homes burning down is no longer what medical intervention is. And so I don't think there is an answer to the end-of-life care question that doesn't involve individual choice. And I think the way we're doing it is saying, society will pay for you to spend 6 months effectively dead in a hospital, but you can't have that money if you just want to take the grandkids to Disney World for one last trip. I'm not sure that's a good choice that society's made. And I'm not sure there's any way to solve this question in the political realm, and I don't think Americans want this question to be decided politically.
But isn't it killing our healthcare system?
Well, I just think it's one of many symptoms of what happens, which is if you say anything medicalized is paid for, you do have expansion of what's considered a medical decision. And that's all I'm saying about end-of-life care. I don't know how to resolve it except to have a system in which we all have the funds to say, here's how I want to die. I want to be kept alive till my last molecule. I want to be put down after that last good game of tennis. I want to die at home. I don't want any interventions. I want a lot of interventions. Until we recognize that those are individual choices, not choices that CMS can make, I don't think we're going to have a satisfactory answer. I don't know whether we spend too much or too little on end-of-life care. I don't. Because it's a matter of individual choice and preference, I think. Sir?
David, I'm wondering if you could say anything at all about how this has impacted you. The catastrophe that's part of your title. Was it a catastrophe for your family? Did you get sick?
Well, I didn't get physically ill, but I will tell you that losing, look, my father was 82. I knew he wasn't going to live forever, but he was in very good health, and I thought it would happen for a few more years. And it is a loss I think about every day. I think everybody who loses a parent thinks about that parent every day. I think that's just the nature of being alive. Bob, that's probably a better question for you than for me to answer. But that's always sticks with you, and you suspect you're going to deal with that at some point in your life. I think, interestingly, the biggest emotional response was my sister's. Because my sister is an emergency room physician. And I think what shocked her is that this whole thing happened kind of on her watch. And yet there was nothing she could do about it. And in these moments, she saw in a way you don't see when you're inside the profession, which, by the way, huge problem with healthcare is that it's all insiders talking about this stuff. But for an insider for a second to be an outsider and say, wow, this is kind of all on autopilot. If I, a physician, can't deal with this, how does the average person deal with this? And this is why I talk about something all the time that I think most people don't think about, which is customer service. We know placebos work in healthcare. Why? They make us feel better. Is there anything about going to a hospital that doesn't make you terrified? And often that's just if you're visiting somebody. If you're the patient, I mean, that relationship between provider and patient is so screwed up in this country because the patient's not the customer. And it's screwed up in a lot of places, by the way. I don't know if you're aware, but when you look at patient satisfaction in Canada, it's lower than here, right? And there it's not a matter of money. All the healthcare is effectively paid for. In the UK, it's disastrous, right? It is, look, I think after my dad died and I read Atul's piece, and Atul jokes to me sometimes that if he only hadn't written that piece, I never would have written the book. Because Atul, is a culture guy. He's like, doctors have to solve this ourselves. We don't need outsiders. I think it's just shocking if you live in 21st century developed country, just how low the standards are. And since I've joined Leapfrog and actually see all the error data and all the plane error, you say to yourself, this is a place where airplanes almost never crash anymore. How is this possible? And of course, once we're in the healthcare system, we're so scared, right? I mean, Arrow's right. We're not great consumers. But that's all the more reason they've got to be at least as good as the cell phone guys. But of course, they're much worse than the DMV. Sir.
You describe a situation in which you talk about family traveling with the patient through their care. Now that doesn't happen too often, but within this room there are any number of individuals who are going to have a role as a patient advocate.
Yeah.
Through bioethics involvement or through patient advocacy, that kind of thing. What advice in terms of this problem? You're putting a person inside that system who's really, their job is really to be outside the system in a certain way, to insinuate. What kind of advice can you offer to those folks?
So I think, our own personal experiences are small by definition. So I can just tell you from my own perspective what I've learned. And recently as the father of a kid who needed emergency surgery, what it's like, is that this is the institution in our life that probably requires us to be most skeptical, most questioning, most unwilling to go with the flow. And that's a very difficult thing because it's a time of anxiety, and certainly the culture of medical care is a lot less imperial and detached than it used to be. but still is more than most other professions. And I guess the two great roles that I see you can play is, as an outsider, as a loved one, is to be the skeptical advocate, to kind of be the squeaky wheel. And by the way, it's one of the reasons hospitals run terribly is because there's tons of squeaky wheels, because there have to be, and that means a poor allocation of resources, but that's a system we're dealt as patients. And then I think the second is, and it was shocking to me, my father was a physician and a psychiatrist. My father and my mother had never talked about end-of-life care. And he was 82. And part of it, of course, when you reach 82 is you don't want to think about it. I don't want to think about it at 53. And of course, at 30, it's inconceivable. You're going to live forever, so why have the conversation? But interestingly, I think one of the roles you can serve is really to recognize that healthcare is about personal preference in many, many ways. Chronic conditions, cancer, increasingly are about how do I want to treat this? How aggressive do I want to be? How much do I want to sacrifice quality of life or potential quantity of life is often a case. There's obviously a lot of bioethics issues that are complicated. But I think to be the loved one who has a best sense of the individual's preferences and values is an enormous value you serve, not just if the person becomes incapacitated and capable of making decisions, but just to have someone to talk to. Because the system itself isn't great at those conversations. You're still a patient. Sir?
To invert that question, where do you see the role of the insiders in that situation, the physicians and other healthcare providers? What would you recommend to those people in terms of trying to work towards solving some of these issues?
So, my perspective is very heavily a business person's and an economics person. And I meant what I said before, which is since I've started doing this, I've met a lot of near saints. And they're the problem. They're a huge problem. Because they prevent us from seeing the problems in the system. Oil executive comes in here and says, the best thing for this world is cheap oil. It's an important argument, worth listening to, worth thinking about, but you say to yourself, well, that's how his company makes money. I get the connection. Makes me skeptical. Doesn't make me uninterested, but it makes me skeptical. Healthcare folks get the chance to say, we know what's best for you. This isn't about us. It's about you. And for many of them, it's true, right? Which is a big problem. One of the best hospital chains in the country is regarded as Geisinger's in central Pennsylvania. President loves them. Lots of healthcare guys love them. And I had dinner with the guy who runs Geisinger's, and he said, the president views us as a model for other hospitals. And since I'm a very diplomatic guy, I said, well, that's a terrible idea. Right? That's the worst idea I've ever heard. Right? That's like saying the model for our junior high school basketball team is the Olympic dream team. Right? You're LeBron, and you're Dwight Howard. And no. We're not. Geisinger's went out and paid a ton of money and hired some of the best people in the country. So that's not an option for everybody, right? By definition, that doesn't work. That works if you can afford it and you have a protected monopoly like they do. What we need in healthcare is those things that enable the mediocre to achieve above average results, or above results that we have today. And that's why I focus on economic incentives. There's an episode of The Simpsons where Homer is required to supervise employees, and he has absolutely no idea how to supervise anybody. And he says, are you guys working hard? And they say, yes, sir. And he says, could you work harder? Yes, sir. Well, that doesn't do it. What you need are economic incentives. And I think what you need is, because people have economic incentives in healthcare, they just point in the wrong direction. My cardiologist gave up Medicare this year. It's almost inconceivable for a cardiologist to do so. A quarter of his practice, actually probably a third of his practice, is Medicare patients. Because of his Hippocratic oath, he's going to see them for free. He still has a better deal getting away from all the rules and regulations of Medicare and seeing 2/3 of his practice outside of those rules and 1/3 for free. So that's bad incentives. That doesn't work, right? And we don't allow a price system to operate. We don't allow anyone to make money by being cheaper and better and more accessible. And until we do, until we allow those real competitive urges to drive what people do every day, we're relying on their just working harder and being better. That's terrific in your hospital. It's terrible across 5,000 hospitals. It just has no meaning. And that's what we're stuck with in healthcare now, I think. Sir?
I don't hear anything about prevention as opposed to the whole side of the bone. This system seems to be based upon it's more lucrative for the whole side of the bone to take care of the problem as opposed to educating people in health risks of what they do.
So it's the ultimate, I think, society question when we move from a focus on healthcare, which is where we are now, to a focus on health. And I think your statement is a completely correct one about policy and priorities. On a national basis, over the last 2 generations, we've shifted 15% of GDP and are proposing doing another 5% from everything else in life, much of which affect prevention and health, to health care. Imagine a town that said, you know, we're no longer going to invest in fire retardant materials. We're no longer going to teach people fire safety. We're no longer even going to tell kids not to light matches. We're just going to have the biggest, best fire department in the world. That's what we've done. That's a social choice we've made.
And the other thing that you have indicated with your sister was obviously very personal. And what I find, because I do this type of work, I sue doctors in hospitals.
Right.
They're in a bubble. They don't think they do anything with it. Everything's a bad result. And they are really thick-headed.
This
They're telling them, taking their hearts out of their head to get the result.
Right.
And it's remarkable.
Well, because it's a system, in fairness, it's a system that believes in internal discipline, that professional boards can effectively internally discipline. And the rest of everything else, we believe in external discipline.
But they don't report themselves.
I completely understand. As I said, as in Leapfrog, we get all this data, and we try to figure out what the factor of underreporting is. It's enormous. But I just want to get to your first question for just a minute, because I think, keep in mind that the bulk of spending in this country going forward on healthcare is going to be on chronic conditions. And keep in mind that the percentage of Americans who at some point in their lifetime will be diagnosed with a chronic condition is 100. 100%. We will all have one. Part of it is we've relentlessly expanded the definition of chronic conditions. Relentlessly, right? We now have pre-hypertension. It's a chronic condition. Look it up. Right? Why? There's a pill that treats it. It's now a chronic condition. The choice we've made is that rather than do the things that make us healthier, right? I take a statin. Thank you all for paying for part of my statin, right? If instead I chose just to eat less meat and fewer donuts and actually worked out a little bit, you all wouldn't have to pay for a statin. Societal choice that was. You'll pay for the statin. And we're doing it in everything. And, you know, nobody wants to be ill. Everyone wants to live well. But let's remember the social choice we've made. We'll pay for the fire department, not for the fire retardant pajamas.
Here in East Harlem, around summer, they took away the educational program to educate the population. It has a 20% incidence of diabetes, which is remarkable.
Yeah. So when the statistics I did about different countries' lifespans, once you're an OECD country, so once you're a rich country, the number one variable it looks like in variation in lifespan is education. Ma'am?
I believe I've read that there are some groups of physicians who have tried to implement a system that incentivizes the physicians to save money.
Mm-hmm.
They are compensated if they save money for the group, for the patients. And I don't know whether you could talk a little bit about that. I'm familiar with that.
So there's a couple elements of that, right? One is that the government is experimenting with changing fee-for-service with bundled payments. It's a long conversation. I actually don't think it works because I think bundled payments actually make it easier to hide costs and prices, right? I mean, interestingly enough, in the rest of the economy, your ability to bundle indicates market power. Being required to charge fee-for-service indicates a lack thereof. But Medicare, under the Affordable Care Act, is paying something called accountable care organizations, bundled payments on a per capita basis for their patients. And then the idea is the accountable care organization, if it can spend less money on that patient than the average Medicare patient, gets to split the savings, and arguably they share it with their physicians and other. It hasn't worked in the first year. I can, if we had another couple hours, I can tell you why it's probably not going to work at all, because in fact it runs. If you were an economist, not a healthcare economist, you would recognize that accountable care organizations are local monopolies. Local monopolies do not mean prices go down. But they don't understand market power. They think they've made it more efficient. The other aspect, which I think is more interesting, and which I'd like to end with if I can, is what I call the accidental genius of the Affordable Care Act. So I think the Affordable Care Act got almost everything wrong. Almost everything wrong. And not because we don't want people to be covered. I'd like to see universal catastrophic health insurance. But because almost every problem it's solved by making it worse because it lives in this healthcare bubble, this island of healthcare economics. Interestingly, though, one of the great unanticipated consequences of the Affordable Care Act is that almost everybody in this room is going to have a high deductible insurance plan, and far higher deductible than we thought. Right? So high deductible in the corporate world meant $1,000 for an individual, $2,500 for a family. The administration's been very stingy with the data on the exchanges, but it looks like a significant percentage of people are buying $5,000 high deductible plans. Unfortunately, those areas where you were most likely to have price competition, preventive care and contraception, have been removed from deductibles, which will actually make the cost of them higher. I know many of you don't understand why, but your cost of contraception will go up enormously because of this. You just won't see it. You'll think it went down. And those were the areas where competition had the best chance of driving prices down. But interestingly, unless you get a serious illness in this country, outside of preventive care and contraception, most of what you pay for health care is going to come out of your pocket. Which means all the stuff I'm talking about is likely to happen. Because if you're a provider, you say to yourself, almost everybody who walks through the door now is a paying customer. Now I have to tell them the price because they're going to ask. And maybe I have to do a deal with them, and maybe I have to lower my prices, and maybe it's cheaper to see me in the middle of the day than it is during prime time hours, and maybe I actually become like a business. I think a lot of good things are going to come out of that. It sounds terrible. Sounds awful. Oh my God, I got to pay $5,000 a year for my health care in addition to insurance. But it was coming anyway. Cost was already there. It's just now, it's in your hand. What I finished the article in the Atlantic with, what I'd like to finish with now, is imagine a Medicare system like Singapore's, where instead of Medicare paying the hospital, they paid you. And you paid the hospital. You were the customer. Do we really think they'd kill 100,000 people a year in hospital-acquired infections if they had to go to my mom and say, here's the bill, as opposed to go to Medicare? I don't think so. Anyway, thanks so much for tonight. I really appreciate your invitation.